Okay, welcome. So we are talking about bipolar disorder this evening. This is a group project presentation for general psychology, the peer-reviewed presentation. I will be going over the presentation. I'm Opsita Harder. We have Miss Haj Abdur and Miss Serena Bailata. Okay, so definitions here that we are going to be going over in this presentation. We will be talking about social anxiety disorder, bipolar disorder, and cognitive behavioral therapy. We're going to mainly be focusing on bipolar disorder and the treatment for it, which is cognitive behavioral therapy. To start off, we have social anxiety disorder. It is extreme anxiety of regular everyday interactions that forces the individual to hyper-focus on embarrassment and self-consciousness by fear of being judged. People with social anxiety disorder will refrain from social interactions to avoid humiliation or fear of offending others. Bipolar disorder. It manifests as a multifaceted mental health condition marked by alternating episodes of intense manic highs and debilitating depressive lows, frequently accompanied by additional comorbidities. Lastly, we have cognitive behavioral therapy, which is a therapeutic approach to help individuals change certain behaviors that are unhealthy and unhelpful to address negative feelings, ways of thinking, by encouraging self-help strategies designed to improve quality of life. We're going to go a little bit more in depth on the two different types of bipolar. We have bipolar 1 and bipolar 2. Bipolar 1, the symptoms during a manic episode are severely compromised key areas of life functioning and lead to enduring diagnosis. One manic episode, or unusually elevated moods in which the individual might feel very happy, irritable, up with a marked increased activity level. So if you take a look over here to the figure, we have bipolar 1 disorder, and it is characterized by at least one manic episode. Bipolar 2, it is characterized by depressive episodes and less severe mood elevation compared to bipolar 1 disorder. It involves hypomanic episodes where functionality may not be significantly compromised. A little bit more detail about hypomanic episodes would be that individuals may enjoy heightened state of energy, activity, alertness, and may even take advantage of the different states. So over here, again, looking at the figure, we have bipolar 2 disorder, which includes one major depressive episode with an episode of hypomania. What are the effects of having bipolar disorder and social anxiety disorder? So we have a little quote here. Comorbidity is defined as the presence of more than one disorder in a person in a defined period of time. People with bipolar disorder face an increased likelihood of encountering adverse outcomes because of the simultaneous presence of social anxiety disorder. Cognitive behavioral therapy serves as the foremost intervention for social anxiety disorder. However, research backing this suggestion has often overlooked individuals grappling with bipolar disorder paired with social anxiety. Based on a recent study, researchers found more than half of people with bipolar disorder are likely to develop an anxiety disorder in their lifetime, and a third of them will manifest an anxiety disorder at any point of their life. Lastly, mood dysregulation in bipolar disorders includes impulsivity, risk-taking behaviors, and interpersonal conflicts. These are the different mental challenges to bipolar disorder and social anxiety. We have extreme highs, which are the mania symptoms. It's usually an extremely joyous and happy mood state that enables the individual to engage in reckless behavior that others view as out of control, out of character, or dangerous. During a manic episode, you may inadvertently say or do hurtful things when others attempt to assist you, leading to a strain and fractures in your relationships. So, yeah, these can be really detrimental to relationships that you have in your personal life, whether they be more intimate or family relationships. These are just some of the things that can harm those relationships. We have extreme lows, which are depressive episodes. A person with bipolar disorder and social anxiety disorder will have an increased risk of suicidal behaviors than someone with one disorder. We have self-isolation. Bipolar disorder poses greater challenges and disrupts daily life more than extensively compared to managing a single disorder. As symptoms escalate, you might withdraw from social interactions and experience overwhelming anxiety, making routine tasks like shopping or socializing with friends daunting and or burdensome. And lastly, another example we have is substance abuse. Many individuals with bipolar disorder and social anxiety disorder attempt to remedy this disorder with excessive use of alcohol or drugs that make their symptoms worse. So even when people tend to rely on drugs or alcohol, they think that it's making their symptoms better, but in reality, it is not. Even medication like antidepressants tend to amplify symptoms and increase their chances of manic episodes. So these are just a few symptoms that we have here. If you look over to the figure, there's a little bit more details on the different symptoms. We're going to go over the physical challenges for bipolar disorder and social anxiety disorder. We have here the systemic inflammation immune dysregulation, which is upregulation of inflammatory pathways, elevated levels of peripheral inflammation. The brain abnormalities are structural brain abnormalities in bipolar disorder, primarily affect prefrontal and temporal cortex, cingulate gyrus, and subcortical regions. These are less consistent abnormalities and are observed in the insula and visual cortex. They also have enlarged ventricles and are also common in bipolar disorder. Lastly, when someone is going through a manic episodes are consistently associated with gray matter decrease, predominantly in the prefrontal cortex. So if we take a look here over at the figure on the left, we can see that we have the brain, which is not going through a hypomanic episode. It's, pretty thick, pretty normal looking brain here. When the individual is going through a hypomanic episode, you can see the deflation of the thickness in the brain here. So this is the feeling of, your brain literally is like tight and, something's going on. We are going through a hypomanic episode. These are the anatomical locations of the brain regions in which negative correlations between thickness, changes rates, and the number of hypomanic episodes between imaging time points were observed in the Enigma bipolar disorder study. We have some treatment plans for people experiencing and going through bipolar disorder and social anxiety disorder. First, we're going to start off with the diagnostic assessment. This is conducted prior to study entry by a research nurse or assistant using the structured clinical interview for the DSM-5 disorders. There's also diagnosis agreed upon in a consensus meeting with the first author, a licensed clinical psychologist. The next step would be treatment protocol. Eligible participants are offered 16 sessions of cognitive behavioral therapy for social anxiety within 20 weeks. After the 20 weeks, there is a follow-up with a 3 monthly based booster session. So that's just going to be the participants come in once a month on a 3-month basis. Next, we have the assessment procedure. This is the end of treatment assessment conducted by a research nurse or assistant after the 16th session, and the follow-up assessment is conducted after 3 months. Lastly, there is the session adjustment. Standard number of sessions is typically 14, but 2 additional sessions are added. To those standard sessions, there is address of depressive symptoms, anticipated to be more frequent in people with bipolar disorder, and they try to address any social anxiety related thoughts and images specific to people with bipolar disorder. Now, some more detail about cognitive behavioral therapy for individuals with bipolar disorder and social anxiety disorder. So, first we have the core components. When cognitive behavioral therapy is being taken place, this is where our brain is actively being worked out. So, we have collaboratively developing a personalized cognitive model of social anxiety, conducting an experimental exercise to demonstrate the negative effects of self focused attention and safety behaviors, providing video and still photo feedback to update negative self imagery, implementing attention to training to practice externally focused attention, conducting behavioral experiments to test patients' negative beliefs by dropping safety behaviors, focusing attention externally in social situations, and purposefully displaying feared behaviors or signs of anxiety. And this is the development of the therapy blueprint. Lastly, there are additional treatment components. The participants were given surveys to loosen their beliefs alongside the experiments. They addressed anticipatory worry and post event rumination. There was memory work, which is, they went over discrimination training and memory rescripting to reduce the impact of early social trauma experience. And there were also additional techniques to address persistent negative self beliefs and self criticism. In this slide, we go over some of the data of this case study. So, this case study took place in Halifax, Nova Scotia, Canada. The participants of this case study were recruited from the outpatients attending the mood disorders program in the location. All of the participants had been diagnosed with bipolar 1 and bipolar 2, along with social anxiety disorder, by their treating psychiatrist. So here in this figure, they are using the Leibowitz Social Anxiety Scale self-report before treatment, after treatment, and at a 3-month follow-up. So all of the colored fine lines represent the A through K participants. And then the thick red line in the middle indicates the average score of all the 11 participants. So as you can see here at the very beginning of the study, everybody is very high up on the score scale here towards the middle. We have the after cognitive behavioral therapy and have the end of the 3-month follow-up. So there was a very good change. There was a very good decrease in the scores of the individuals who did follow through with the therapy. And over here to the right, we have the scores of the social phobia inventory scale before treatment, after treatment, and along with the 3-month follow-up. Again, the fine lines indicate all 11 participants, A through K, and then the thick black line in the middle is the average score of the participants. So again, you can see the very good decrease there of the scores. So it looks like there was a lot of good scoring through the therapy. Okay, so after reviewing everything, we said navigating the interplay between bipolar disorder and social anxiety disorder, it presents a challenge in itself when it comes to diagnosis and treatment. Individuals grappling with both conditions confront heightened risks, including impaired social functioning and increased susceptibility to suicidal behavior. While cognitive behavior therapy holds promise as a primary means to help with managing comorbid bipolar disorder and social anxiety disorder, it overall needs more research. Best practices is tailoring treatment to specific challenges such as depression and substance abuse, and identifying symptoms earlier often offers hope for improving outcomes with this complex illness. So that is our presentation for bipolar disorder and social anxiety disorder. Hope you enjoyed. Have a good evening. Thank you.